Welcome to Chapter 23, Behavioral and Psychiatric Emergencies and Suicide. We do a lot of this in EMS, a lot of behavioral medicine, excuse me, I'm turning my phone down, a lot of behavioral medicine, whether it be anxiety, depression, suicidal ideations, actual suicide attempts. And sometimes these suicide attempts aren't really attempts, they're just more of a way to ask for help, and they just don't know how, other than to take a handful of pills. So we do see quite a bit of this. So this is, although it's kind of a dry chapter, it's a pretty important one. So why do we have these behaviors? Stress, both physical, emotional, financial, okay? Physical trauma or illness. So a head injury, you come off your skateboard, you slam your forehead on the ground, you can have an immediate emergency, but it can also cause long-lasting disease processes that have flare-ups, and we end up seeing folks that way. Drugs and alcohol, and then just psychiatric conditions, whether it be schizophrenia, manic depression, anxiety, etc. So a behavioral emergency. Behavior is a manner in which that person acts. An emergency is when that behavior is outside the acceptable norms. Now, think about what this slide says to a patient, to the family, or their community. So different communities, different societies are going to have some different attitudes about what is or is not normal behavior. Excuse me. So sometimes it's as simple as they're a little confused or they're a little altered. And what's a little altered? A little confused, or maybe a little anxious. Some of the conditions we see, I've already mentioned them: anxiety or panic disorder. I feel bad for all these folks, but anxiety is probably one we see more than anything, and it can strike anybody at any time. Some folks are more prone to it and are chronically affected by it. And I feel really bad for these folks because it could be anything that sets them off. And by setting them off, what I mean is scared, somebody's, they can't control something, somebody's trying to control them, their life is out of control. And sometimes it's just their brain feels out of control. They can't get themselves back on an even keel. And I think of the term there, but for the grace of God go I, because it's super easy for this to affect anyone. Depression, right? Things are in their mind so bad, they don't have the energy to do anything. They are upset. Again, it can be chronic over a lifetime, or it could be around a specific event in life. Bipolar, we tend to think of the manic depressive, manic with the whole everything's high, fast, and then the highest of highs, and then the lowest of the depression lows. Okay. Schizophrenia, a break with reality is a common definition of that. Kind of the religious, I'm Jesus, I'm God, God's told me to do that. Those are kind of the common ones that we see. Now, there are things that will mimic this. Low blood sugar, number one. Any patient with a altered mental status, a little confused, anxious, whatever, still check a blood sugar. Even though they tell you they have a history of anxiety and they take medications for it, and this is exactly what it feels like, just to be safe, check their blood sugar. Get a full set of vital signs, right, including pulse oximetry. History of the present illness, right, events leading up to it. Did you fall off your bicycle, right? Did you bump your head? Drug use, alcohol use, and then environmental, right? So take a temperature on these folks. You know, maybe they're hypermetabolic because they're fighting an infection, and that's causing them to be febrile, and that can certainly cause them to have these symptoms. Urinary tract infections, probably the number one cause of altered mental status in elderly females is a UTI. You know, when you come into an ER and you bring your mom in, and you know your mom's 75 or 80, and you say, "Well, she got a little confused this morning, and she's just not acting right." Here's a cup. Go pee in the cup. It's the first thing we want to rule out, and then blood sugar. Now, situational reactions. We are supposed to be scared of things. We are supposed to grieve when things go bad and we lose people or pets or friends, you know, family. And we are supposed to be angry when things are done to us or around us. We're supposed to be angry. I read an interesting article once about 10 years ago, maybe 12 years ago, that said we are supposed to be, right, angry, scared, and grieve. But what we're doing is we're medicating this out of people from an early age. You know, you go to your doctors, your PCPs, mid-level, whatever, and you say, "Oh, you know, my mom died and I'm really upset and I'm just having a tough time getting," and they go, "Okay, hey, here's your whatever," and they diagnose something, prescribe something rather. You know, you're supposed to be scared if you're screwing up at work and you're afraid you might get fired. You should be scared. Being scared that you're screwing up and you're going to get fired should motivate you not to screw up anymore, right? But if we're medicating that stress reaction out, yeah, I'll just get another job. You know, so, and this was an article in a psychology magazine too, mind you, okay? Now we're probably medicating too much of this stuff out of our society nowadays. You need some help with something. I went through a time frame where I was depressed, probably, you know, a few weeks to a month, and I went to my provider and said, "Look, this is what's going on. I just need something to help me for 30 days. I don't want to be on anything longer than that. I just need help through this acute phase." And she was on board with that. She said, "Yeah, absolutely. Here you go." And by the time that 30-day period went by, I was feeling better. Well, was it that my depression or the events causing it were better? Or was it the Wellbutrin? I don't know. I stopped the medicine because that's what I said I was going to do. And I got through that time frame. Okay. So there's nothing wrong with getting some medication for an acute event, but we shouldn't be on it for the rest of our lives if we're not chronically overwhelmed. So these calls can sometimes take the longest time frame, and our bosses don't like that, right? Sometimes contractually we're contracted for 20-minute scene times, no more than 20 minutes. This call could take you 45 minutes to an hour. Be calm, be cool. Don't rush the things. Let the folks know what you can do and what you can't do to help them. But be honest. You know, listen to the patient, be honest with them. Don't lie to them. "Oh, yeah, we're going to take you to the ER. Everything's going to be fine." "Oh, they're going to keep me locked up in a room." No, they're not. Yeah, there's a good chance they are. Okay. So Don't lie to people. Say, look, I don't know what the ER is going to do. I know that when you get there, you're going to see the nurses and the doctors. They're going to make sure there's not something metabolically, like chemically wrong. Do some lab work. Then make sure you haven't banged your head, things like that. And then you'll see somebody as far as a counseling type evaluation. Could be face to face or could be on video. But other than that, I can't tell you what they're going to do, and I have no control over that. But let's take in and let's try to get you some help. Okay. Changes in behavior. They're angry, and all of a sudden they shut up. That's a warning sign. Unusual silence could be a warning sign that they're about to take a swing at you. Look for body language. They're bouncing on the balls of their feet. Their fists are opening and closing. They're tensing muscles up. That's a sign that they're very well may take a swing at you. Acute psychosis is an acute break in reality. Okay, so they're not able to process some information, or they're not able to interact appropriately with those around them. And this is a very common thing with schizophrenia. Hallucinations, delusions. What's a delusion? Delusion is a feeling of being something you're not. So one of the terms is delusions of grandeur. You are somebody way above your pay grade, right? I mean, you are a world leader. You're a general. You're special forces when you couldn't even get into the military, right? You are God, or God's telling you to do things. Catatonia, lights are on, nobody's home. You're just, eyes are open, but you're just staring. And it's not kind of like you're deep in thought. It's just you don't see or hear anything else going around you. And then thought disorders, just you're not thinking straight. Things with this, one of the biggest things for us with this is safety of us, safety for the patient as well. Okay. Now, all kinds of presentations, from quiet and withdrawn to throwing punches and trying to stab people. Okay. Withdrawn, not talking to us, agitated, bizarre behavior, and wanting to hurt people. So one of the questions we ask is, have you had any thoughts about hurting yourself or someone else? And by the way, over the years, I've heard lots of different things about that. What I was originally taught was, oh, you shouldn't ask them if they want to kill themselves because you might put that thought in their head. No, we're not. No, that thought was there long before we walked in the room. Okay. Not once have I ever said to somebody, hey, have you thought about hurting or killing yourself or someone else? And they went, bingo, my God, that's the answer. Nope, never seen it. What you see is, well, I kind of thought I wish I was dead, or yeah, I think I'd like to kill myself, or I don't deserve to live, or I don't think I deserve to live, or no way, no, I could never do that. That's kind of the range of answers that I get when I ask people this question. And it is advocated by the mental health experts that you ask that question. We walk into these scenes in a uniform. A lot of times wearing blue pants and a blue shirt. Could be dark blue, could be light blue, could be a white shirt. What do police officers wear? Blue or black pants, blue, black, or white shirts. Some EMS departments wear badges. What do cops wear? Badges. All right. Police officers tend to be antagonistic, either in actuality or in their mind. Maybe because of their behavioral emergencies in the past, maybe they've had a bad interaction with a police officer, or at least bad in their mind, right? They get taken down, they get handcuffed, they get stuffed in the back of a cruiser. To me, that would be a fairly negative interaction. So you need to identify yourself. Hey, my name's Kevin. I'm one of the medics. I'm with the ambulance. I'm not one of the police officers. What's going on? And I say that. I'm not one of the cops. What's going on? Because sometimes they're also afraid of being arrested for maybe something that's causing this event, the drugs or alcohol. And I tell them, look, whatever you tell me is in strict confidentiality, right? There are federal laws that control that. What you and I say to each other is between you and I, and the docs when we get to the hospital, okay? Slowly, clearly, eye contact, but not eye contact, right? Don't stare people down. You know, I look at them, you know, I'm looking at you when I talk, and I look over here when somebody else talks, I look back at you when I ask you a question. Police officer walks in the room, I turn, I look to see who's coming in, but I'm not staring you down, okay? Listen and don't be judgmental. Listen, you know, sir, I'm here to help you. Nothing you say is going to make me think bad of you. You know, I'm here to help you. Body language, like I said, are they bouncing on their feet? Are they flexing muscles? Are they grinding their teeth? And acknowledge patient's feelings. This is one of these big HR kind of things nowadays, right? You go in and they're teaching management this. Okay, Kevin, so I understand that you're upset about being sent on this transfer. Okay, that's a little too touchy-feely for me. But with these patients, it's perfect, right? Dude, I get it. You're pissed at your wife because you're pissed at your brother. You're depressed because you lost. You know, I'm really sorry. I can't imagine what you're going through now, right? That's the other thing. Remember, I said, you know, don't lie. You may have just gone through this same event, right? It may be a breakup. Wife left you. Wife left them. Don't look at them and go, I know how you feel. You could say, look, I just went through a similar event. I can imagine what you're feeling right now because I just went through it myself. Say that's okay. But if you tell somebody, hey, I know what you feel, no, you don't, because they feel things differently than you do, and vice versa. Personal space. Societies, different communities, different societies have a different idea of what personal space is. Some people, face to face is perfectly acceptable, and it creeps me out. I want you 3 feet away from me, and I want to be outside of that 3 feet from them. It's also a safety issue. If I'm more than 3 feet away, right, that's grabbing distance, that's punching distance. It gives me a little bit of a cushion to step sideways or step backwards. Changes in emotional status, right? That upset, pissed off to quiet, that's always bad. If you have to protect them or you, and that's kind of a weird thing to think about. I'm going to tie you down to protect you. Yeah, because if you aren't throwing punches at me and the police officer, then you're not going to get hurt back. Now, this is an awful photo, right? These guys are all very aggressive towards this dude. They've got him surrounded. They got their hands up. Their feet are in a fight position. And this is an awful photo. Plan your approach in advance. No, this is horseshit. This is going to get you punched, kicked, bitten. Are there times where you have to take him down? Yes. 5 people ideally. A couple of police officers would be nice. They do a lot of training on taking people to the ground. We don't, okay? If you can get 1 person for each limb and a 5th person to actually talk them through what's going on and to control the head if you have to. Stay out of reach of their teeth. Folks bite. I've seen a lot of people get bitten through the years. So, assessment. Scene size up, super important. How are they acting? How are they looking, right? What do I see, hear, and smell? Do I smell drugs? I'm sorry, do I see drugs and alcohol? Do I smell alcohol? How are they acting? Identify yourself, right? Primary assessment. And this is that from the door, they're speaking full sentences. You know their airways open, you know their breathing's probably good. How is their skin color? All right. I always ask them, hey, listen, one of the things I have to do is I have to do kind of a head to toe thing, or I get in trouble. You don't mind if I kind of poke and push in a few places, do you, to make sure that, nothing hurts, you don't have any big bruises. Is that okay? And a lot of times these folks say, yeah, sure, go ahead. And what I'm really doing is I'm looking for weapons. I'm looking for guns, knives, clubs, baseball bats, shotguns tucked down their pant leg. Okay. So as much of a detailed exam as necessary. And then I try to get a history. I try to get it from them and or their family. So signs and symptoms commonly, panic and anxiety, certainly. If they are so overwhelmed by whatever this process is, a lot of times hygiene and personal care doesn't get taken care of. Agitated, unusual activity, unusual speech patterns, flight of ideas. They're going off about, I can, like right now I'm looking at a Mickey Mouse oven pad. God damn, I hate mice. I hate rats. I hate Disney. And then they're off on, my boss said this to me. And they're, God's telling them to, it's just this flight of ideas, okay? Which goes with behavior and thought patterns as well. Now, suicidal self-destructive behavior. There are people, they're cutters. A lot of times it tends to be females, but you'll see they make all these cuts on their arms and legs where they have kind of easy access. It's not suicidal. It is a self-harming behavior. They're not going to get IEA'd for that. IEA, involuntary emergency admission, or IEH, you'll hear that phrase, involuntary emergency hospitalization. They're not going to get IEA'd for cutting. A cut, they cut their wrist, yes, they're going to get held for that and evaluated. Okay. Scene safety, life-threatening problems, right? Glucose, oxygen, head traumas, and the things that cause those. Like I said, take time. This call can take a while. You sit in the back of the ambulance. I see a lot of times now. I see people. I'm going to sit right behind you. I'll be right here, and they sit behind them. No, sit where you can sit and talk with them face to face, and talk to them on the way to the hospital. Ask them questions. Get them talking to you. Okay. Do not play along with hallucinations. I'm seeing snakes and spiders and ants, and sir, I promise you they're not here. I know that's what you're seeing, and I know it's scary. The only kind of time I skirt this issue a little bit is I will create a safe zone for them. If they are on a front porch and they're seeing spiders and snakes, I want them to go to the hospital, right? I will create a safe zone. Listen, sir, in the back of my ambulance, I guarantee you, we did a full truck check earlier. There are no snakes, there are no spiders. Anything you see in there is not real. I promise you that. And I get them into the ambulance that way. I'm skirting the issue. I'm not playing along with the hallucination, except that I'm promising them that this area is a safe zone for them. I heard that, and it's funny, I heard a comedian talking about safe zones while you're tripping on acid, right? You got to keep one guy straight, and he creates that safe zone. Like the couch is the safe zone. When you're on the couch, nothing can hurt you. And that's right from the beginning of their trip. And I kind of thought that makes a lot of sense. Creating a safe zone for these people. It could be LSD, right? LSD, you're hallucinating. Psychosis, you're hallucinating. Create a safe zone for them. Involving family or friends. do that appropriately. If their family or friends are their trigger point, you get them out of the room. If the police officer is the trigger point, get them out of the room. Now, suicide, third leading cause of death in late teens, early 20s. Older adult population, the number one most successful population for suicide is elderly elderly males. And the reason for that is they use guns. They don't fool around, right? They've lost their family. Their families all died or left. Their friends are all dying off. They have health and financial problems, and they're not vain in the least. 75-year-old guy's like, I don't care about an open coffin. Puts a gun in his mouth, pulls the trigger. Women don't even joke about gunshots. If they make a statement about shooting themselves, that is the most, in my mind, the most serious suicide threat I hear. They don't even joke about it. And I'm not being sexist. This is just one of those. It carries out. It carries across. You see it. Teenage girls, adult females. They've got the dress picked out that they want to be buried in, with the outfit. They want the open coffin. They want, and pills, right? Older guys, shotgun in the mouth, boom, gone. It's quick, it's guaranteed. So think about those things when you see them or hear them. Some of it is certainly just they don't know how to ask for help. They cut their wrist, but they don't cut it well, right? But they cut it enough so that it can be seen and somebody can approach them about it. Or they take a handful of pills and they tell somebody, they text somebody, they leave the pill bottle where it can be found. They just don't know. They don't know how to ask, or they're scared to ask. So it's one of the questions I ask them. Listen, were you trying to kill yourself, or were you just trying to ask for help? And a lot of times I hear, just trying to ask for help. And when I say a lot of times, I've worked in several systems where there is a lot of this. Rochester, right? 20 something years in Rochester, I saw a lot of this, okay? The ERs that I've worked in, we see a lot of walk-ins with these complaints and these issues. So yes, I've asked this question a lot, and most of the time I get, I don't really want to kill myself, right? But every once in a while, they're like, no, it didn't work this time. I'll make it work next time. Okay? So, depression, high stress levels, currently, recently, or recurrent. Age, drug or alcohol abuse. So why do people drink? Some people drink so they can beat their wives. It's a proven fact. Oh, my husband's a nice guy until he drinks and then he beats me. He drinks so he can beat you. Proven fact, okay? People drink to lower their inhibitions. I want to beat her, but it's wrong. But if I drink, then I can. I want to kill myself, but it's wrong. So if I get drunk, maybe I can, okay? These are proven facts. If they've threatened suicide. Now, the other thing is, do you have a plan, right? And again, not once have I ever heard, oh, a plan. I need to plan this out. No shit, figure that out. No, they'll either go no, or, I was kind of thinking about pills, or, I've got this gun at home, or yes, I've got a plan. Yes, I've got the rope at home. I've already tied the knot. Okay. So the more definitive the plan, the more definitive the plan, right? Have you tried anything like this before? Have you been hospitalized for it? Do you take any medicines for it? This sudden improvement from depression is they have made their decision and they are now comfortable with it. You get this guy at work who's just been depressed for weeks and everybody feels bad for him and they're trying to cheer him up. And he comes in Monday morning and he's better. He's happy. He's friendly. He's made his decision. He's got his plan. He's made his decision. He knows when he's going to do it. He knows how he's going to do it. And he's now happy that this time of misery is almost over. Big warning sign. So again, be calm, cool, collected. Don't argue and threaten them. There may come a time, though, you spent 20, 30 minutes trying to talk this person into it. There may come a time when, listen, you got a choice to make. You can come with me in the back of the ambulance. We'll have a nice, easy ride in. We'll just sit and shoot the shit. Or you're going to ride in with the police officers. You know, you've threatened to kill yourself. You've lost that constitutional right to make your own decisions. I'm sorry, it's the law. You've threatened to kill yourself or somebody else, or to hurt yourself or somebody else. We legally have to take you in. Like I said, you can ride with me or you can ride with them. That's as far as I go. I give them that choice. I don't threaten them. You're coming with me or they're going to drag you in. No. Here's your choice, sir. You can ride in with me, we can keep shooting the shit, or you can ride with them. Which would you prefer? I'm not going with you. Officer, he's all yours. Boom. And I've already had that discussion with the police officer, you know, so we're on the same page. Safety, treat life-threatening events. Extreme agitation, combativeness, you need ALS. You need a paramedic to come in and give this dude either some Haldol and Versed or some ketamine and knock them down. It's called chemical restraint. We sedate them and make them compliant with what we want to do so that they don't get hurt and we don't get hurt. Give the ER notification, not 30 seconds out. I like to give them as much as possible. If I've got a 30-minute transport, I'm going to get on the phone with them at the 30-minute mark and say, hey, we're bringing somebody in. You need, you know, if you got room 123 available, right? That's the psych room at Huggins, secure psych room. You might want to make it available. Okay. Good. And this, think about it, is something that I've seen a lot. He said, she said, he said. Patient's 23-year-old male, his girlfriend calls 911 after a domestic dispute. He's uncooperative, refusing treatment. Hey, leave me alone. I didn't fucking do anything. This is bullshit. She's making this up, trying to get me in trouble. She says he's been depressed, suicidal, has a gun, is threatening to shoot himself. This is a tough one. If she is willing to fill out paperwork, it's called, in New Hampshire, it's called a prayer and complaint. She's witnessed this. We have not. The police officer has not. We're hearing him adamantly deny it. If she is willing to fill out this prayer and complaint and have that this is what she heard, then we or the police officers can take him against his will. Otherwise, if he's alert, oriented, not under the influence of drugs or alcohol, he's got the right to refuse care. And maybe she is trying to get back at him. You know, she's striking out at him. But maybe he's abusive. Maybe he is threatening it, right? So having a discussion with a police officer on scene about this and how they feel about it. Having a discussion with medical control on the phone. And then go from there. And if med control says, no, he's awake, he's alert, he's oriented, she's not willing to do any paperwork, you can't take him against his will, then I'm going to document that. If the police officer agrees with, all three of us agree, oh, this is, you know, this is the way it is. Have him sign a refusal. And then I'm going to have her sign as the witness. Ma'am, I'm not saying you agree with this. I'm just saying that you saw him sign this for us, please. And if not, then I have the police officer sign. Okay? So, should we believe her? Well, yeah, but again, if he's adamant about it, you know, this is a super hard one. Okay? So, that's it. That's what we got. Oh, no, I got a couple more slides. Sorry about that. Now, aggressive or hostile patients, always have an escape route. Do not let people get between you and the door. Always know where your escape route is. Don't threaten them. Stay alert for weapons. Anything can be used as a weapon. Cane, baseball bat, certainly, right? Plates, dishes, knives, weapons, guns. Try to calm them. However, understand when it's time to leave. You're being physically aggressive. I don't feel safe. I'm out. Police officers come back in. Maybe now it's time to restrain them physically with straps and preferably chemically. If we are restraining somebody physically nowadays, we should have ALS chemically restraining them also. It goes hand in hand. The ERs do it. We do it. New Hampshire EMS wants us to do that, chemically restrain people. It is safer. There's this thing called excited delirium. It is a hypermetabolic state. Generally, people with a psych history and a drug ingestion of some sort of amphetamine or cocaine, and it just trips this trigger in their brain. And the National Police Chiefs Association, in conjunction with their medical directors, okay, came out with a slideshow on it. And their term for this is batshit crazy. Okay, they're batshit crazy and super strong. And you find them naked a lot because they're hyper metabolic. Their temps are high and they're batshit crazy. They have no cognitive recognition of reality right now. And they're super hot. They're febrile. And so they strip their clothes off trying to cool down. And you find them naked all the time. And they're fighting. These medical directors from the police departments like New York City and Miami and whatnot, they came up with the protocols that New Hampshire uses, which is, Haldol and Versed or ketamine. Sedate them. These people have a high risk for cardiac arrest. Okay. Size up, med control if you need it, sudden changes in behavior, reassess, and consider restraint. Now, reasonable force with restraint. What is reasonable to protect them or us from injury versus lethal force? Lethal force is they are projecting a potentially lethal threat to me. I can respond with lethal force. They pull a knife and they're trying to stab me. You can bash their head in, okay? But smashing their head in with an O2 tank when they're arguing with you is not reasonable force. Reasonable, their size and their strength. If you are a 110-pound person, male or female, and this dude is 275 pounds and jacked, you have a reasonable right to believe that you could be injured significantly by them, okay? What is their behavior, their mental status? What do you have available to restrain them? And sometimes not restraining them until you get ALS is the best avenue. You know, let them rant and rave and storm around their kitchen and break dishes and shit while you stand back. And then when the medics show up and they look and go, oh yeah, boy, whew, yeah, we got to drop him. They can draw up their, 4 milligrams per kilo of ketamine. Everybody jumps on the dude for 10 seconds while the medic injects them, and then everybody jumps off and backs away again. The chemical profile for ketamine says that intramuscular 4 milligrams per kilo, within 4 minutes, they will lay down and go to sleep. My experience with this is it's actually about 1.5 minutes to 2 minutes. Boom, down they go. Now you can safely put them on a scoop, strap them to the scoop, put them on the stretcher, put some stretcher straps on them, and put limb restraints on them. 4-point restraints, ankles and wrists, or the police officers can zip tie them, whatever you guys have available. But it's far safer once they've been chemically dropped. Some systems do not allow restraint without either med control or police. State of New Hampshire, it says you do what you have to keep yourself and them safe. So here's that excited delirium. So usually preceded by cocaine. You got to remember when excited delirium started becoming a known event or known condition, cocaine was a big deal. Coke and crack. Well, now, bath salts and meth and all those sorts of hypermetabolic drugs, right? Speeds. Now, the reason these medical directors for New York City and Miami specifically got involved in this was they were having these people thrown in the backs of cruisers, and they ended up on the floor and positionally suffocated. And so the ACLU, American Civil Liberties Union, was saying the police officers were killing them, and they weren't. So they came up with this protocol, and let's transport them in an ambulance with people who can properly reassess them and keep them alive. And once the drugs wore off, typically this excited delirium went away also. So we've already said this. Get enough help, plan it out ahead of time, stay out of their reach until you're ready to go. And then when it's time to go, it's time to go. Okay? Restraining them, somebody should try to talk them down while it's going on. It doesn't work a lot, but at least it makes everybody feel better. One at a limb, always, always, always do not let legs and arms come loose because you're going to get punched or kicked every time. Leather restraints were a big deal for a long time, but now because of infection control issues, we use a lot of disposable things. Right? I'm not a big fan of zip ties just because of how narrow they are, and they can cause some damage distally as far as either circulation goes or localized tissue damage. Always supine, so flat on their back. I like them flat on their back, sitting up a little bit, just 15, 20, 30 degrees, and that allows better ventilation, right? Takes the stress off the diaphragm. One of the good ways of doing is what's called swimmer's position. Think about swimming and you're doing this, right? So if you've got one arm down and one arm up over their head, when you get this arm strapped to the stretcher behind them, they can't come forward because that shoulder restricts them. But if you got both hands down here, they can sit up. Okay, so I prefer swimmer's position. It's what's recommended as well. We are responsible for them once we restrain them. Okay, so airway, circulation, masks. Well, hey, it's COVID. We put masks on everybody. A lot of these patients spit. In the state of New Hampshire, by the way, as an EMS person, police, fire, and EMS all carry the same extended penalties now for assaulting us. If you get spit on, that's an extended sentence for assault. In the state of New Hampshire, they can get 2 to 5 years. You get spit on, demand the police department presses charges. They may not know it. Your department may have never run into this. City of Rochester, about 20 years ago, they started enforcing this. If we got spit on, punched, kicked, swung at, they went to jail. There was no second guessing it. Okay. ER medical staff as a whole should be covered by this. They're not. I disagree with that. It is what it is. So spitting patients, what we used to do with spitting patients a lot, we'd put a non-rebreather on them, pull the bag off and the little disc so they could still breathe, and then a lot of times that got taped around their head. You run 3-inch tape around that mask all the way around their hair 4 or 5 times, that mask's not coming off because they'll try to get it off and then spit at you again. Surgical mask, if you can. Non-rebreather though, all the openings open so that you're not affecting their breathing. Works wonderfully. Police departments, a lot of them carry spit hoods. I would ask them. Spit hood has a solid spot from here down, but it's mesh around the top, kind of like a fancy bug net. Document it absolutely thoroughly. Know what you have around you for facilities. These people go to ERs. They don't go to psych hospitals. Okay, they go to ERs where they're evaluated initially. State of New Hampshire, all ERs handle this stuff. They don't want to, but they have to. Now, consent. If we can get a legal consent, and what I mean by legal, right? Are they competent? Are they not under the influence of drugs and alcohol? Then, and they refuse, and we can get that refusal signed, then yeah, go ahead. I always get it witnessed by family member if I can. You make those magic statements. You're a threat to yourself or somebody else. Most states, you lose that right to refuse. Okay. Sexual misconduct. This happens. People act out in a sexual way. They grab at us. They grab themselves. They talk about what they want to do to us or with us, or what they want to do by themselves. Stay out of reach. Try to ignore it. If you can have a female attend in the back of with a female psych patient, you're better off. I've had a couple of friends accused of raping a psych patient. It was a nightmare. So I try not to. And in fact, I believe in the state of Mass, it's required to have same sex in the back. New Hampshire, it's not. So EMS services will just, no, you take them. If I can get a female police officer, if it's an all-male crew, I want a female in the back of me. Firefighter, rescue, or police officer. Okay. All right, so that is Chapter 23, Behavioral and Psychiatric. If you got any questions, shoot me a text, shoot me an email, leave me a message below. All right, thanks, and I'll see you later, Chapter 24.